Do you want to successfully complete the D514 Objective Assessment exam? Then you are in the right place. Our website provides a list of questions and answers for your success in the D514 OA exam for free. We understand that acing your OA exam can be quite challenging. That's why we provide completely free exam guides and practice questions for you. In this video, we will cover questions from Statistical tests, healthcare databases, research designs, data types, and ethical principles. So, let's get started. 1. Which statistical measure is most appropriate for analysing patient satisfaction survey data, where responses are ranked on a Likert scale from very dissatisfied to very satisfied? A. Nominal. B. Interval. C. Ratio. D. Frequency. Can you guess the answer? Correct answer, D. Frequency. Explanation: option D is correct, because frequency counts the number of responses falling into each ordered category on the Likert scale, which is ideal for ordinal data like satisfaction levels. Option A is incorrect, because nominal data represents categories without any inherent order, such as types of insurance, which doesn't apply to ranked satisfaction levels. Option B is incorrect because interval data has equal intervals but no true 0 point, like temperature scales, which is not the structure of satisfaction surveys. Option C is incorrect because ratio data requires a true 0 point, like infection rates, which is absent in ranked satisfaction responses. Alright, let's break down the core concept behind this question about data types in healthcare. When hospital administrators analyse patient satisfaction surveys, they're working with ordinal data, which is data that has a clear order or ranking. Think of it like a staircase where you can tell which step is higher, but the distance between steps might not be exactly the same. Satisfaction surveys use Likert scales ranging from very dissatisfied to very satisfied, and this creates a natural ranking system. The key here is that order matters, but we don't have perfectly equal intervals between each satisfaction level. That's why frequency is the most appropriate statistical measure for ordinal data, because we can count how many people fall into each ranking category. Nominal data would just be categories with no order, like types of insurance or medical specialties, so that doesn't fit here. Interval data requires equal intervals with no true 0, like temperature scales, which isn't how satisfaction surveys work. And ratio data needs a true 0 point, like infection rates or percentages, which doesn't apply to ranked satisfaction responses either. 2. A quality improvement team needs to compare infection rates across 3 or more hospital units. Which statistical test should they use to handle all groups at once? A. Chi-square test. B. Paired t-test. C. ANOVA. D. Mann-Whitney U-test. Do you know the answer? Correct answer, C. ANOVA. Explanation: option C is correct because ANOVA, analysis of variance, is designed to compare the means of 3 or more groups simultaneously by analysing the variation within each group and between groups. Option A is incorrect because the chi-square test is used for categorical variables, not for comparing numerical means across multiple groups. Option B is incorrect because the paired t-test is used to compare 2 related groups, such as measurements taken from the same subjects before and after a treatment. Option D is incorrect because the Mann-Whitney U-test is a non-parametric test used to compare 2 independent groups, not 3 or more. Let's explore the principle behind statistical tests for multiple group comparisons. When a quality improvement team needs to compare infection rates across 3 or more hospital units, they need a test that can handle all groups at once. This is where ANOVA, which stands for Analysis of Variance, becomes the perfect tool. Think of it like a referee comparing the performance of multiple teams simultaneously, rather than doing one-on-one comparisons. ANOVA looks at the variation within each group and the variation between groups to determine if the differences are statistically significant. The beauty of ANOVA is that it does this all-in-one analysis, which is much more efficient and statistically sound than running multiple, separate tests. Chi-square tests are designed for categorical variables, like examining if there's a relationship between insurance type and readmission, not for comparing numerical means. Paired t-tests only work when you have two related groups, like measuring the same patients before and after treatment. And Mann-Whitney U is a non-parametric alternative for comparing just two groups, not three or more. So when you see three or more groups being compared on a numerical measure, ANOVA is your go-to statistical test. 3. A researcher wants to examine how medication adherence rates have changed over 5 years by collecting data at multiple predetermined intervals. Which research design are they conducting? A. Meta-analysis. B. Time series analysis. C. Cross-sectional study. D. Case study. Can you guess the answer? Correct answer, B. Time series analysis. Explanation: option B is correct because time series analysis involves collecting data at multiple points in time to examine changes and trends over an extended period, which aligns with the scenario of tracking medication adherence rates over 5 years. Option A is incorrect because meta-analysis combines the results of multiple studies rather than collecting new data over time. Option C is incorrect because a cross-sectional study collects data at a single point in time, providing a snapshot rather than tracking changes over time. Option D is incorrect because a case study involves an in-depth investigation of a single subject or situation, not systematic measurements at regular intervals. To really understand why time series analysis is the correct choice, let's dive into the theory of research designs that track changes over time. When a researcher wants to examine how medication adherence rates have changed over 5 years by collecting data at multiple predetermined intervals, they're conducting a time series analysis. Imagine it like taking snapshots of the same scene at regular intervals to create a flipbook that shows motion and change. The key characteristics are sequential data collection, predetermined time points, and the ability to identify trends and patterns over an extended period. This is fundamentally different from a cross-sectional study, which is like taking just one photograph at a single moment in time, giving you a snapshot but no sense of change. Meta-analysis is about combining results from many different completed studies, not to collecting new data over time. And case studies focus on deep investigation of a single subject or situation, not systematic measurements at regular intervals. Time series analysis is perfect for tracking adherence, infection rates, patient volumes, or any metric where understanding the pattern of change over time is crucial for healthcare decision-making. 4. In a study examining the effectiveness of a new treatment on patient recovery, a healthcare analyst finds that age significantly affects recovery rates, obscuring the true effect of the treatment. In this scenario, age is best described as what type of variable? A. Independent variable. B. Confounding variable. C. Dependent variable. D. Dichotomous variable. Do you know the answer? Correct answer, B. Confounding variable. Explanation: option B is correct because a confounding variable is a factor that obscures or interferes with the relationship between the independent and dependent variables. In this case, age is affecting patient recovery rates, making it difficult to determine the true impact of the new treatment. Option A is incorrect because the independent variable is the treatment itself, which is being manipulated to see its effect on recovery. Option C is incorrect because the dependent variable is the patient recovery rates, which is the outcome being measured. Option D is incorrect because a dichotomous variable has only two possible values, such as yes, no, or male, female, and age has many possible values. This is a critical concept for understanding research variables, So let's dig into what makes something a confounding variable. In this scenario, a healthcare analyst is trying to figure out if a new treatment actually helps patients recover, but age keeps getting in the way of seeing the true effect. This is the textbook definition of a confounding variable, which is a factor that obscures or muddles the relationship between the variables you're actually trying to study. Think of it like trying to hear a conversation in a noisy restaurant where the background noise makes it hard to understand what's being said. Age is interfering with the treatment-recovery relationship, making it difficult to know if improvements are from the treatment or just because younger patients naturally recover better. The independent variable would be the treatment itself, because that's what researchers are actively manipulating or controlling. The dependent variable is patient recovery rates, because that's the outcome being measured that depends on the treatment. A dichotomous variable just means something with two possible values, like yes or no, which doesn't describe age since it spans many possible values. Understanding confounding variables is crucial because they can lead to false conclusions if not properly controlled for in research design. 5. A hospital requires a database to store vast amounts of patient data from numerous healthcare organizations and to execute intricate queries from diverse viewpoints. Which type of database is most suitable for this purpose? A. Flat file database. B. Relational database. C. Transactional database. D. Data warehouse. Can you guess the answer? Correct answer, D. Data warehouse. Explanation: option D is correct because a data warehouse is specifically designed for massive data storage, integration from multiple sources, advanced data mining, and processing data from different perspectives, making it ideal for the hospital's needs. Option A is incorrect because flat file databases are simple and limited, unsuitable for handling large volumes of data from multiple organizations or complex queries. Option B is incorrect because relational databases are better for connecting tables within a single organization, but lack the capacity and multi-organizational mining capabilities required for this scenario. Option C is incorrect because transactional databases are designed for real-time operations, such as processing lab orders, rather than storing and analyzing historical data from numerous sources. Let's break down the essential characteristics of different database types to understand why a data warehouse is the answer here. When a hospital needs to store enormous amounts of patient data from multiple healthcare organizations and run complex queries from various perspectives, they need something far more powerful than a simple database. A data warehouse is specifically designed for this massive scale. Think of it like a huge library that not only stores millions of books from many different publishers, but also has an incredibly sophisticated cataloging system that lets you find information from any angle you can imagine. The key features are huge data storage capacity, the ability to integrate data from multiple organizations, advanced data mining capabilities, and processing from multiple perspectives or dimensions. A flat file database is like a single spreadsheet, way too simple and limited for this level of complexity. Relational databases are great for connecting tables within one organization, but they don't have the massive storage and multi-organizational mining capabilities needed here. Transactional databases are built for real-time operations like processing lab orders right now, not for storing and analyzing historical data from many sources. Data warehouses enable strategic planning and decision-making by bringing together huge amounts of information and making it accessible for complex analysis. 6. What database is used in medical centers to track trauma injury cases, keep detailed records, and generate public health reports? A. Object-oriented database. B. Multidimensional database. C. Disease registry. D. Transactional database. Do you know the answer? Correct answer, C. Disease registry. Explanation. Option C is correct because disease registries are specifically designed to track individual cases of a particular disease or condition, maintaining detailed records and generating reports for public health purposes. Option A is incorrect because object-oriented databases are designed for storing multimedia data, not for tracking individual patient cases over time. Option B is incorrect because multidimensional databases are focused on quick processing of large datasets, but lack the case-specific tracking features needed for a disease registry. Option D is incorrect because transactional databases manage real-time operations, which differs from the long-term case tracking that disease registries provide. Alright, let's explore what makes disease registries so essential in healthcare data management. When a medical centre wants to track all trauma injury cases, keep detailed records of each incident, and generate public health reports, they need a specialised database called a disease registry. Think of a disease registry like a dedicated filing system specifically designed for one type of medical condition, where every case gets its own detailed folder that tracks the patient journey from diagnosis through treatment and outcomes. Trauma registries, cancer registries, and other disease-specific registries serve three critical functions. Case-specific tracking, so every incident is documented, detailed record maintenance that captures comprehensive information about each case, and public health reporting that helps identify trends and improve community health. Object-oriented databases are designed for storing multimedia, like medical images, videos, and audio files, not for tracking individual cases over time. Multidimensional databases focus on quick processing and ad hoc reporting of large datasets, but they don't provide the case-specific tracking structure that registries need. Transactional databases handle real-time operations like processing lab results with rollback capability, which is completely different from the long-term case tracking that registries provide. Disease registries are essential tools for quality improvement, research, and public health surveillance. 7. Which national healthcare database should a hospital administrator access to verify a physician's credentials and check for malpractice history before granting clinical privileges? A. CDC, B. CMS, C. HSCAPS, D. NPDB. Can you guess the answer? Correct answer, D. NPDB. Explanation: Option D is correct because the National Practitioner Databank is a national repository of information about malpractice payments and adverse actions related to healthcare practitioners. Option A is incorrect because the Centers for Disease Control and Prevention focuses on public health data, such as disease outbreaks and mortality rates, not individual practitioner credentials. Option B is incorrect because the Centers for Medicare and Medicaid Services primarily manages data related to Medicare and Medicaid programs, including reimbursement and quality measures, but not practitioner credentialing. Option C is incorrect because the Hospital Consumer Assessment of Healthcare Providers and Systems is a patient satisfaction survey, not a source for verifying physician credentials or malpractice history. This question tests your understanding of national healthcare databases and their specific purposes. When a hospital administrator needs to verify a physician's credentials and check for malpractice history before granting clinical privileges, they must access the National Practitioner Databank, abbreviated as NPDB. Think of the NPDB as a national background check system specifically for healthcare providers, maintaining a comprehensive record of every malpractice payment, adverse licensure action, and clinical privilege issue across the entire country. This is a critical safety mechanism that prevents practitioners with problematic histories from simply moving to a new state and starting fresh. The CDC, or Centers for Disease Control, focuses on completely different data. They track births, deaths, marriages, divorces, disease surveillance, and morbidity-mortality statistics, not individual practitioner credentials. CMS, the Centers for Medicare and Medicaid Services, maintains Medicare and Medicaid data, hospital quality scores, and reimbursement information for financial and quality purposes, not practitioner credentialing. HC Apps is a patient satisfaction survey tool with questions about hospital stays used for quality measurement and reimbursement, but it has nothing to do with checking physician credentials or malpractice histories. Understanding which national database serves which purpose is essential for healthcare leaders who need to access the right information for decision-making. 8. A research team collects temperature readings in Celsius from ICU patients. Which type of data are they working with, given that it has equal units between measurements but no true 0 point? A. Nominal data. B. Ordinal data. C. Interval data. D. Ratio data. Do you know the answer? Correct answer, C. Interval data. Explanation: option C is correct because interval data is characterized by equal intervals between values and the absence of a true 0 point. Temperature in Celsius fits this description. Option A is incorrect because nominal data consists of categories or names with no inherent order or numerical meaning. Option B is incorrect because ordinal data involves ordered categories or rankings where the intervals between the ranks are not necessarily equal. Option D is incorrect because ratio data has equal intervals and a true 0 point, indicating the absence of the measured quantity. This is a critical concept for understanding research variables, so let's dig into what makes something a confounding variable. In this scenario, a healthcare analyst is trying to figure out if a new treatment actually helps patients recover, but age keeps getting in the way of seeing the true effect. This is the textbook definition of a confounding variable, which is a factor that obscures or muddles the relationship between the variables you're actually trying to study. This equal spacing is what makes it interval data. However, and this is crucial, interval data doesn't have a true 0 point, where 0 means the complete absence of what's being measured. 0 degrees Celsius doesn't mean there's no temperature, it's just the freezing point of water. This is totally different from nominal data, which is just categories or names with no numerical meaning at all, like naming different types of cancer or insurance plan. Ordinal data has order or ranking, like pain scales or satisfaction surveys, but the intervals between ranks aren't necessarily equal. Ratio data is similar to interval data with equal units, but it has that true 0 point, like infection rates where 0 means no infections at all, or weight where 0 means no weight. Understanding these distinctions helps you choose the right statistical methods for analysis. 9. Which statistical test should a quality team use to determine if there's a significant association between patient insurance type and likelihood of readmission within 30 days? A. F-test. B. Z-test. C. Pearson's correlation. D. Chi-square test. Can you guess the answer? Correct answer, D. Chi-square test. Explanation: option D is correct because the chi-square test is specifically designed to test associations between categorical data, such as insurance type and readmission status. Option A is incorrect because an F-test compares variances between populations and is not suitable for assessing associations between categorical variables. Option B is incorrect because a Z-test is used for comparing means with large samples and known variances, not for examining relationships between categories. Option C is incorrect because Pearson's correlation measures the strength and direction of linear relationships between numerical variables, not associations between categorical variables like insurance type and readmission status. Now let's tackle an important concept about choosing the right statistical test for categorical variables. When a quality team wants to determine if there's a significant association between patient insurance type and likelihood of readmission within 30 days, they're examining the relationship between two categorical variables. This is the perfect scenario for a chi-square test, which is specifically designed to test associations between categorical data, Imagine you have a grid showing insurance types across the top and readmission status, yes or no, down the side. The chi-square test looks at the actual observed frequencies in each cell of this grid and compares them to what you'd expect to see if there was no relationship between insurance and readmission. If the observed and expected values are very different, that suggests a significant association. An F-test is completely different. It compares variances between populations using their ratio, which has nothing to do with categorical associations. A Z-test is used for large samples with known variances when you're comparing means, not examining relationships between categories. Pearson's correlation measures the strength and direction of linear relationships between numerical variables like age and blood pressure, not associations between categories like insurance types. The key is recognizing that insurance type and readmission status are both categorical, not numerical, so you need a test designed for categorical data. 10. Which ethical principle is prioritized when a research ethics committee ensures that participants are fully informed and can freely choose whether to join a study without coercion? A. Beneficence. B. Justice. C. Fidelity. D. Autonomy. Do you know the answer? Correct answer, D. Autonomy. Explanation option D is correct because autonomy is the ethical principle that emphasizes the right of individuals to make informed and voluntary decisions about their participation in research, free from coercion or undue influence. It ensures that participants have the power to decide what happens to their bodies and health. Option A is incorrect because beneficence focuses on acting in the best interests of participants and maximizing benefits while minimizing harm, but it does not directly address the freedom to choose participation. Option B is incorrect because justice concerns the fair distribution of research benefits and burdens across different groups, but it doesn't specifically deal with the individual's right to choose participation. Option C is incorrect because fidelity relates to maintaining trust, loyalty, and keeping promises made to participants, which is different from the right to make a voluntary decision about participating. Let's explore the fundamental ethical principles that guide all research involving human subjects when a research ethics committee is reviewing a study and ensuring that participants are fully informed and can freely choose whether to join without any coercion. They're prioritizing the principle of autonomy. Think of autonomy as the ethical foundation that says every person has the right to be the boss of their own decisions, especially when it comes to their body and their health. This principle encompasses informed consent, which means explaining the research in plain language so people truly understand what they're agreeing to, and it also means making absolutely sure there's no pressure or manipulation that might make someone feel they have to participate. Beneficence is different. It focuses on actively promoting participant welfare and acting in their best interests, like making sure the research might actually help them. Justice addresses fairness, ensuring that we're not always using vulnerable populations for risky research while wealthy populations get all the benefits. Fidelity is about loyalty and keeping promises, making sure researchers maintain truthfulness and advocate for participants. While all these principles are important, autonomy is specifically about that fundamental right to make your own informed, voluntary decision about participation without anyone forcing or tricking you. 11. A hospital epidemiologist wants to understand how many patients currently have a hospital-acquired infection at a single point in time. Which study is this? A. Longitudinal study. B. Meta-analysis. C. Cross-sectional study. D. Randomized control trial. Can you guess the answer? Correct answer, C. Cross-sectional study. Explanation option C is correct because a cross-sectional study is like taking a snapshot at one point in time, ideal for understanding current prevalence. Option A is incorrect because a longitudinal study follows the same group over an extended period. Option B is incorrect because a meta-analysis combines results from multiple completed studies to get a bigger picture. Option D is incorrect because a randomized control trial involves assigning people to different intervention groups and tracking outcomes over time. This is about understanding different research study designs and when to use each one. When a hospital epidemiologist needs to understand how many patients currently have a hospital-acquired infection at a single point in time, they're conducting what's called a cross-sectional study. Think of cross-sectional like taking a photograph. It captures everything exactly as it exists in that one frozen moment. This type of study is perfect for prevalence questions, which ask how common something is right now, not how it changes over time. It's like taking attendance in a classroom to see how many students are present today. A longitudinal study is completely different because it follows the same group over an extended period, like taking multiple photos of the same scene over weeks or months to see how things change. Meta-analysis involves systematically combining results from multiple completed studies to get a bigger picture, not to collecting new data at a specific moment. Randomized control trials involve assigning people to different intervention groups and tracking outcomes over time, which is way more complex than just counting current cases. The key word here is snapshot. When you need to know what's happening right now at this moment, cross-sectional is your answer. 12. A clinical researcher has collected data that doesn't follow a normal distribution and needs to compare two sample means from the same population. But the standard t-test assumptions can't be met. Which statistical test should they use? A. ANOVA, B. F-test, C. Mann-Whitney U-test, D. Pearson's correlation. Do you know the answer? Correct answer, C. Mann-Whitney U-test. Explanation: option C is correct because the Mann-Whitney U-test is a non-parametric test specifically designed for comparing two independent groups when the data is not normally distributed. Option A is incorrect because ANOVA is a parametric test used for comparing the means of three or more groups and assumes normal distribution. Option B is incorrect because the F-test is used to compare the variances of two populations, not the means. Option D is incorrect because Pearson's correlation measures the linear relationship between two variables, not the difference between group means. Here's a crucial concept about when to use non-parametric statistical tests. When a clinical researcher has collected data that doesn't follow a normal distribution and needs to compare two sample means from the same population, but the standard t-test assumptions can't be met, they should use the Mann-Whitney U-test. Think of non-parametric tests as the flexible backup plan when your data doesn't behave the way parametric tests need it to. Parametric tests like regular t-tests assume your data is normally distributed, like a classic bell curve, and they assume certain other conditions are met. But real-world data is often messy and doesn't follow those perfect patterns. That's where the Mann-Whitney U-test comes in. It's specifically designed as a non-parametric alternative that works with ordinal data or non-normally distributed data when comparing two groups. ANOVA is a parametric test for comparing three or more groups and needs those same normal distribution assumptions, so it won't work here. Pearson's correlation measures relationships between variables, not comparing means between groups. And the F-test is about comparing variances, asking if two groups have equal spread in their data, which is a different question entirely. The key is recognizing when your data violates parametric assumptions and switching to the appropriate non-parametric alternative. 13. A healthcare administrator wants to predict future emergency department visit volumes based on multiple factors like season, day of week, and local event schedules. Which analytical technique are they using? A. Risk adjustment, B. Factor analysis, C. Stratification analysis, D. Predictive modelling. Can you guess the answer? Correct answer, D. Predictive modelling. Explanation option D is correct because predictive modelling uses historical data and various factors to forecast future outcomes, such as predicting emergency department visit volumes based on seasonal trends, day of the week, and local events. Option A is incorrect because risk adjustment is used to make fair comparisons between different hospitals or units by controlling for differences in patient complexity. Option B is incorrect because factor analysis helps identify which variables in a large dataset are most important. Option C is incorrect because stratification analysis divides a population into subgroups for analysis. Let's dig into advanced analytical techniques and when to use them in healthcare. When a healthcare administrator wants to predict future emergency department visit volumes based on multiple factors like season, day of week, and local event schedules, they're using predictive modelling. Think of predictive modelling as a sophisticated crystal ball that uses mathematical algorithms and historical patterns to forecast what's likely to happen in the future. It takes all those different factors, sometimes called predictors or independent variables, and combines them using statistical formulas to calculate probability outcomes. This is incredibly valuable for planning, like knowing you'll probably need extra staff during flu season or on Friday nights. Risk adjustment is different. It's about making fair comparisons between different hospitals or units by statistically controlling for differences in patient complexity. Factor analysis helps you figure out which variables in a huge dataset are actually important and which ones you can ignore to simplify your analysis. Stratification analysis divides your population into homogeneous subgroups before you sample or analyze, like separating patients into age groups. The keyword that signals predictive modelling is forecast or predict. When you need to anticipate future volumes, needs, or outcomes based on current data patterns, predictive modelling is the tool you reach for. 14. A quality improvement director wants to measure the strength and direction of the relationship between nurse staffing ratios and patient satisfaction scores, where both variables are measured on interval scales. Which analysis should they use? A. Chi-square. B. ANOVA. C. Pearson's correlation. D. Mann-Whitney. U. Do you know the answer? Correct answer, C. Pearson's correlation. Explanation option C is correct because Pearson's correlation is specifically used to measure the strength and direction of a linear relationship between two continuous variables measured on an interval or ratio scale, like nurse staffing ratios and patient satisfaction scores. Option A is incorrect because chi-square tests the association between two categorical variables, not the linear relationship between two continuous variables. Option B is incorrect because ANOVA compares the means of 3 or more groups. It does not measure the strength of a linear relationship between two continuous variables. Option D is incorrect because the Mann-Whitney U test compares the means of two independent groups. It doesn't measure the correlation between two continuous variables. Now we're going to explore correlation analysis and when to use it. When a quality improvement director wants to measure the strength and direction of the relationship between nurse staffing ratios and patient satisfaction scores, where both variables are measured on interval scales, they should use Pearson's correlation analysis. Think of correlation as measuring how two things move together. Do they go up and down in sync? Do they move in opposite directions, or do they not seem related at all? Pearson's correlation gives you a single number between -1 and +1 that tells you the answer. +1 means perfect positive correlation, where when one goes up, the other always goes up by a predictable amount. -1 means perfect negative correlation, where when one goes up, the other always goes down. 0 means no linear relationship at all. They're independent. The beauty of Pearson's is that it works specifically with interval or ordinal level data, which is what we have here with staffing ratios and satisfaction scores. Chi-square is completely wrong because it tests associations between categorical variables like insurance type and readmission, not linear relationships between numerical scores. Mann-Whitney U compares means between two groups. It doesn't measure correlation. ANOVA compares means among three or more groups, again not about measuring the strength of a linear relationship between two continuous variables. 15. In a research study examining a new discharge planning intervention, patients are randomly assigned to either receive the new intervention or continue with standard care. What key characteristic minimizes bias in this study? A. Meta-analysis. B. Random assignment. C. Focus groups. D. Case studies. Can you guess the answer? Correct answer, B. Random assignment. Explanation: option B is correct because random assignment evenly distributes known and unknown differences between patients across both the intervention and control groups. This makes the groups comparable at the start, minimizing bias and allowing for a stronger conclusion that any observed differences in outcomes are due to the intervention. Option A is incorrect because meta-analysis combines results from multiple studies to increase statistical power, but it does not address bias within individual studies. Option C is incorrect because focus groups involve guided discussions with diverse participants to gather qualitative data and do not involve random assignment. Option D is incorrect because case studies provide in-depth investigations of single subjects or cases without using random assignment to compare groups. This question focuses on understanding what makes randomized control trials the gold standard of research. When a research study examining a new discharge planning intervention randomly assigns patients to either receive the new intervention or continue with standard care. The key characteristic that minimizes bias is random assignment. Think of random assignment like flipping a coin to decide which group each patient goes into. This ensures that any differences between patients, whether we know about them or not, are evenly distributed across both groups. This is incredibly powerful because it means that if we see a difference in outcomes, we can be much more confident that it's because of the intervention and not because one group happened to have healthier or sicker patients to begin with. Meta-analysis is about combining results from multiple studies for greater statistical power. It's not about how individual studies assign participants. Focus groups involve diverse participants in guided discussions for qualitative data, which is completely different from the random assignment process in experiments. Case studies provide in-depth investigation of single subjects, again not involving random assignment to different groups. Random assignment is the magic ingredient that separates true experiments from observational studies and gives us the strongest evidence about cause and effect relationships. 16. When a hospital quality committee examines catheter-associated urinary tract infection rates and wants to ensure fair comparisons across different patient populations with varying complexity levels, they need to use A. Factor analysis, B. Predictive modelling, C. Risk adjustment, D. Stratification. Do you know the answer? Correct answer, C. Risk adjustment. Explanation. Option C is correct because risk adjustment uses statistical methods to account for differences in patient populations, allowing for fairer comparisons of healthcare quality metrics. Option A is incorrect because factor analysis is used to identify underlying variables in a data set, not to adjust for patient complexity when comparing infection rates. Option B is incorrect because predictive modelling forecasts future outcomes, but it does not adjust current comparisons of infection rates based on patient complexity. Option D is incorrect because stratification divides populations into subgroups, which is different from using risk adjustment to level the playing field by controlling for patient complexity. Let's tackle the important concept of making fair comparisons in healthcare quality measurement. When a hospital quality committee examines catheter-associated urinary tract infection rates and wants to ensure fair comparisons across different patient populations with varying complexity levels. They need to use risk adjustment. Here's why this matters so much. Imagine comparing infection rates between a community hospital that treats mostly healthy young patients and a tertiary care centre that treats extremely sick patients with multiple chronic conditions. Without adjustment, the tertiary centre would always look worse even if they're providing excellent care, simply because their patients are more vulnerable to infections. Risk adjustment uses multivariate regression analysis to statistically control for these patient complexity differences, essentially leveling the playing field so you're comparing apples to apples. Factor analysis is about identifying which variables in a large dataset matter most and reducing complexity, not adjusting for patient differences. Predictive modelling forecasts future outcomes using algorithms, not adjusting current comparisons. Stratification divides populations into subgroups before sampling, which is a different approach entirely. Risk adjustment is essential for fair benchmarking, quality reporting, and value-based payment systems where you need to account for patient differences. 17. Which type of database is best suited for a healthcare system needing to store patient medical images, diagnostic videos, and audio recordings alongside traditional text-based medical records? A. Flat file database. B. Relational database. C. Multidimensional database. D. Object-oriented database. Can you guess the answer? Correct answer. D. Object-oriented database. Explanation. Option D is correct because object-oriented databases are designed to handle complex data types like images, videos, and audio, making them ideal for storing multimedia data alongside traditional text-based medical records in healthcare systems. Option A is incorrect because flat file databases are simple, single-table structures that can only handle basic text and numbers, not multimedia data. Option B is incorrect because relational databases handle structured data through connected tables, but are not optimized for storing and retrieving multimedia data. Option C is incorrect because multidimensional databases focus on the quick processing of large datasets for reporting purposes, not on storing diverse multimedia formats like medical images and videos. Let's explore specialized database types and their unique capabilities. When a healthcare system needs a database that can store patient medical images, diagnostic videos, and audio recordings of heart sounds alongside traditional text-based medical records, they need an object-oriented database. Think of object-oriented databases as multimedia warehouses specifically designed to handle complex data types that go beyond simple text and numbers. Traditional databases work great with those structured data like names, dates, and lab values, but they struggle with images, videos, and audio files which require different storage and retrieval methods. Object-oriented databases excel at this because they can store objects that contain both data and the methods to manipulate that data, making them perfect for electronic health records in modern healthcare, where you need quick access to X-rays, ultrasound videos, and recorded heart sounds right alongside patient demographics and lab results. Flat file databases are simple single-table structures like spreadsheets that can only handle basic text and numbers. Relational databases handle structured data through connected tables but aren't optimized for multimedia. Multidimensional databases focus on quick processing of large datasets for reporting from multiple perspectives, not on storing diverse multimedia formats. As healthcare becomes more visual and technology-rich, object-oriented databases become increasingly essential. 18. A population health researcher wants to synthesize findings from 15 different studies examining the same intervention to achieve greater statistical power and more definitive conclusions. What are they conducting? A. Time series analysis. B. Case studies. C. Focus groups. D. Meta-analysis. Do you know the answer? Correct answer, D. Meta-analysis. Explanation. Option D is correct because meta-analysis combines the results of multiple scientific studies to develop a single conclusion that has greater statistical power. Option A is incorrect because time series analysis involves collecting sequential data at predetermined intervals over time from a single study to identify trends. Option B is incorrect because case studies provide a deep investigation of a single person, group, or institution through observation. Option C is incorrect because focus groups gather qualitative data through guided discussions with diverse participants. This is all about understanding how to build stronger evidence through combining research findings. When a population health researcher wants to synthesize findings from 15 different studies examining the same intervention to achieve greater statistical power and more definitive conclusions, they're conducting a meta-analysis. Think of meta-analysis as creating a super study by mathematically combining the results of many individual studies, kind of like how combining many voices creates a louder, clearer sound than any single voice. The power of meta-analysis comes from the increased sample size and the ability to identify patterns that might not be clear in individual smaller studies. It's a systematic process that involves searching the literature, selecting high-quality studies, extracting data, and using statistical methods to combine the results into one overall effect estimate. Time series analysis is completely different. It's about collecting sequential data at predetermined intervals over time from a single study to identify trends. Case studies provide deep investigation of a single person, group, or institution through observation, not combining multiple studies. Focus groups gather qualitative data through guided discussions with diverse participants, which is about collecting new data, not synthesizing existing research. Meta-analysis is particularly valuable when individual studies might be too small to detect effects or when results across studies seem inconsistent. 19. A nurse manager collected length of stay data for 28 patients on a medical unit and needs to compare this sample mean to a known population standard. Which statistical test is the most appropriate choice? A. Z-test. B. T-test. C. Chi-square test. D. F-test. Can you guess the answer? Correct answer, B. T-test. Explanation. Option B is correct because a t-test is specifically designed for situations with small to moderate sample sizes, typically less than 30, and it's perfect for comparing means. Option A is incorrect because a z-test would be used instead if there was a large sample size, typically defined as greater than 30, with known population variance. Option C is incorrect because chi-square tests are for categorical variables, asking questions about associations between categories, not comparing numerical means. Option D is incorrect because F-tests compare variances between populations to see if they're equal, which is a different question than comparing a sample mean to a population standard. Now let's understand when to use specific statistical tests based on sample size. When a nurse manager collected length of stay data for 28 patients on a medical unit and needs to compare this sample mean to a known population standard, a t-test is the most appropriate choice. Here's the key principle. T-tests are specifically designed for situations with small to moderate sample sizes, typically less than 30, and they're perfect for comparing means. Think of the t-test as the workhorse of small sample statistics. It was developed to handle the extra uncertainty that comes from having limited data points. When you have a small sample, you have more variability in your estimates. And the t-test accounts for this by using a t-distribution, which has fatter tails than the normal distribution. A z-test would be used instead if you had a large sample size, typically defined as greater than 30, with known population variance. Chi-square tests are for categorical variables, asking questions about associations between categories, not comparing numerical means. F-tests compare variances between populations to see if they're equal, which is a different question than comparing a sample mean to a population standard. The cutoff of 30 is a common rule of thumb in statistics. Below 30, you generally use t-tests. Above 30, you can use z-tests. 20. A quality director needs to collect in-depth qualitative feedback about a new patient portal from users with varying ages, technical abilities, and healthcare needs through moderated group discussions. Which method should they use? A. Focus groups. B. Randomized control trials. C. Cross-sectional studies. D. Time series analysis. Do you know the answer? Correct answer, A. Focus groups. Explanation. Option A is correct, because focus groups are structured conversations guided by a facilitator, ideal for capturing nuanced feedback on attitudes, perceptions, and user experiences, which is exactly the kind of feedback the director needs. Option B is incorrect because randomized control trials are quantitative experimental studies that randomly assign people to different interventions to measure outcomes, not for gathering qualitative feedback. Option C is incorrect because cross-sectional studies capture quantitative data at a single point in time, like measuring prevalence, not facilitating discussions. Option D is incorrect because time series analysis collects sequential quantitative data at regular intervals to identify trends over time, not about gathering qualitative perspectives through discussion. Let's explore qualitative research methods and when they're most appropriate. When a quality director needs to collect in-depth qualitative feedback about a new patient portal from users with varying ages, technical abilities, and healthcare needs through moderated group discussions, they should use focus groups. Think of focus groups as structured conversations where a skilled facilitator guides a diverse group of people through a discussion about a specific topic, capturing rich, nuanced feedback that you could never get from a survey or questionnaire. The power of focus groups comes from the interaction between participants, where one person's comment might spark thoughts in others, leading to deeper insights. They're perfect for exploring attitudes, perceptions, and user experiences in ways that quantitative methods simply can't capture. Randomized control trials are quantitative experimental studies that randomly assign people to different interventions to measure outcomes, completely different from gathering qualitative feedback. Cross-sectional studies capture quantitative data at a single point in time, like measuring prevalence, not facilitating discussions. Time series analysis collects sequential quantitative data at regular intervals to identify trends over time. Again, not about gathering qualitative perspectives through discussion. Focus groups are essential in healthcare for understanding patient experiences, testing new programs before full implementation, and exploring complex issues where numbers alone don't tell the whole story. 21. A hospital pharmacist tracks the number of medication errors per 1,000 doses dispensed, calculating both the frequency of errors and the proportion relative to total doses. What type of data are they working with? A. Nominal data. B. Ordinal data. C. Interval data. D. Ratio data. Can you guess the answer? Correct answer, D. Ratio data. Explanation. Option D is correct because ratio data has equal intervals between measurements and a true 0 point, allowing for meaningful ratio statements and calculations like rates and proportions. Option A is incorrect because nominal data consists of categories without any numerical relationships, such as listing types of medications or insurance plans. Option B is incorrect because ordinal data has ranking or order, like rating pain from mild to severe, but the intervals aren't precisely equal. Option C is incorrect because interval data has equal intervals between measurements, but lacks a true 0 point, like temperature or time measurements. Let's break down an essential concept about classifying numerical measurements in healthcare. When a hospital pharmacist tracks the number of medication errors per 1,000 doses dispensed and calculates both the frequency of errors and the proportion relative to total doses, they're working with ratio data. Think about what makes ratio data special compared to other types of measurements. Ratio data has two critical characteristics. It has equal intervals between measurements, and it has a true 0 point, where 0 means the complete absence of what you're measuring. When we say 0 medication errors, that literally means no errors occurred, which is fundamentally different from 0 degrees Celsius, which doesn't mean the absence of temperature. This true 0 allows us to make meaningful ratio statements, like one unit having twice as many errors as another unit. Nominal data is just categories without any numerical relationships, like listing types of medications or insurance plans. Ordinal data has ranking or order, like rating pain from mild to severe, but the intervals aren't precisely equal. Interval data has equal intervals between measurements but lacks that true 0 point, like temperature or time measurements. Ratio data is the most informative level of measurement because you can do all mathematical operations on it, including calculating rates, percentages, and proportions. 22. A research team studying patient outcomes must ensure their study design distributes potential risks and benefits fairly across all demographic groups without favouring or burdening any particular population. This upholds which ethical principle? A. Autonomy. B. Beneficence. C. Justice. D. Non-maleficence. Do you know the answer? Correct answer, C. Justice. Explanation: option C is correct because justice in research. Ethics specifically addresses the fair distribution of risks and benefits across all demographics, ensuring no group is unfairly burdened or favoured. Option A is incorrect because autonomy focuses on the individual's right to make informed decisions about their participation in research, not the equitable distribution of risks and benefits across populations. Option B is incorrect because beneficence is about actively promoting the well-being and best interests of research participants, not necessarily about ensuring a fair distribution of outcomes across groups. Option D is incorrect because non-maleficence is the principle of avoiding harm to participants, rather than focusing on the equitable allocation of risks and benefits among different populations. Now we're diving into a crucial ethical principle that ensures fairness in research. When a research team studying patient outcomes must ensure their study design distributes potential risks and benefits fairly across all demographic groups without favouring or burdening any particular population, they're upholding the principle of justice. Think of justice as the ethical guardian of fairness that asks, are we treating everyone equitably? This principle has profound implications in research history, where vulnerable populations were often exploited for risky research, while privileged populations reap the benefits. Justice demands that we don't always recruit homeless populations for dangerous experimental trials, while wealthy populations get access to promising new therapies. It requires fair selection of participants and equitable distribution of both the potential harms and the potential benefits across different demographic groups. Autonomy is about individual rights to make their own decisions about participation, which is different from ensuring fairness across populations. Beneficence focuses on actively promoting participant welfare and acting in their best interests, not on ensuring equity in how risks and benefits are distributed. Non-maleficence is about the fundamental obligation to do no harm and minimise potential harm to all participants, but it doesn't specifically address fair distribution across different groups. Justice is what prevents research from exploiting vulnerable populations and ensures that everyone has fair access to potential benefits. 23. Which type of database system is best suited for a laboratory manager needing to handle real-time patient test orders, immediately process results, and maintain the capability to reverse entries if errors are detected? A. Data warehouse. B. Disease registry. C. flat file database. D, transactional database. Can you guess the answer? Correct answer, D, transactional database. Explanation, option D is correct because transactional databases are designed for real-time operations and have the critical feature of rollback capability, which allows reversing incorrect entries immediately, essential for systems like laboratory information systems. Option A is incorrect because data warehouses are used for strategic analysis and large data storage from multiple organizations, not for real-time processing or immediate error correction. Option B is incorrect because disease registries are for tracking specific cases over long periods for public health reporting, not for immediate operational transactions and real-time processing. Option C is incorrect because flat file databases are simple, single table structures lacking the sophisticated features required for real-time operations and rollback capability. This is about understanding specialized database systems and their unique operational capabilities. When a laboratory manager needs a database system that can handle real-time patient test orders, immediately process results, and maintain the capability to reverse entries, if errors are detected, they need a transactional database. Think of transactional databases as the real-time workhorses of healthcare operations, designed for immediate processing of actions that need to happen right now. The key feature here is rollback capability, which is like having an undo button that can reverse a transaction if something goes wrong. Imagine a lab technician enters a critical lab result incorrectly and realizes the mistake immediately. The transactional database can roll back that entry and correct it without leaving a permanent error in the system. This real-time processing with error correction capability is essential for operational systems like laboratory information systems, pharmacy order entry, and registration systems. Data warehouses are completely different. They're designed for huge data storage from multiple organizations for strategic analysis, not for real-time operations. Disease registries track specific cases over long periods for public health reporting, not for immediate operational transactions. Flat file databases are simple single-table structures without the sophisticated features needed for real-time operations with rollback capability. Transactional databases are what keep healthcare operations running smoothly, minute by minute. 24. A pain management clinic uses a scale where patients rate their pain from 0 to 10, with each number representing progressively worse pain levels. This data is best classified as what type? A, nominal, B, ordinal, C, interval, D, ratio. Do you know the answer? Correct answer, B, ordinal. Explanation, option B is correct because ordinal data is characterized by a clear ranking or order, but the intervals between the values are not necessarily equal. A pain scale fits this description, as a higher number indicates more pain, but the difference between pain levels may not be uniform. Option A is incorrect because nominal data consists of categories without any inherent order, such as different pain locations like head, back, or knee. Option C is incorrect because interval data requires equal intervals between all values, which is not the case with subjective pain ratings. Option D is incorrect because ratio data requires both equal intervals and a true 0 point. And while zero pain might seem like a true zero, the subjective nature and unequal intervals mean it does not qualify as ratio data. Let's explore how to correctly classify data from patient assessment tools. When a pain management clinic uses a scale where patients rate their pain from 0 to 10, with each number representing progressively worse pain levels, they're collecting ordinal data, and the key defining characteristic is ranking. Think about what this pain scale really represents. A patient who rates their pain as a 7 is definitely experiencing more pain than someone who rates it as a 3, so there's a clear order or ranking. However, And this is the crucial distinction. We can't say that the difference between a 3 and a 4 is exactly the same as the difference between a 7 and an 8. Pain is subjective. What feels like a 4 to one person might feel like a 6 to another, so the intervals between numbers aren't uniform or equal. This is what makes it ordinal, rather than interval or ratio data. Nominal data would be categories without any order, like naming different pain locations such as head, back, or knee. Interval data requires perfectly equal intervals between all values, which we don't have with subjective pain ratings. Ratio data needs both equal intervals and a true zero, and while zero pain might seem like a true zero, the subjective nature and unequal intervals mean it doesn't qualify as ratio data. Pain scales, satisfaction surveys, and stage of disease classifications are all classic examples of ordinal data. 25. Which analytical technique is used to simplify complex datasets by identifying the most important variables, such as in healthcare research to determine which factors significantly impact hospital readmission rates? A. Predictive modelling. B. Risk adjustment. C. Factor analysis. D. Stratification. Can you guess the answer? Correct answer, C. Factor analysis. Explanation. Option C is correct because factor analysis is used to reduce data complexity by identifying the most important variables that impact an outcome, like hospital readmission rates. Option A is incorrect because predictive modelling uses mathematical algorithms to forecast future outcomes. Option B is incorrect because risk adjustment enables fair comparisons across systems by controlling for patient differences. Option D is incorrect because stratification divides populations into subgroups before sampling. Here's a powerful analytical technique that healthcare researchers use to simplify complex data sets. When a healthcare researcher wants to identify which factors among dozens of variables have the most significant impact on hospital readmission rates, they use factor analysis to reduce data complexity by identifying the most important variables. Think of factor analysis as a detective that sifts through a mountain of potential clues to identify the few critical pieces of evidence that really matter. Imagine you're tracking readmissions and you have data on age, gender, number of medications, length of stay, diagnosis, insurance type, socioeconomic status, distance from hospital, and dozens of other variables. Factor analysis uses sophisticated statistical techniques to figure out which of these variables actually have meaningful relationships with readmission and which ones are essentially noise. This is incredibly valuable because it allows you to focus your improvement efforts on the factors that matter most rather than trying to address everything at once. Predictive modelling is different. It uses mathematical algorithms to forecast future outcomes, not to identify which variables are most important. Risk adjustment enables fair comparisons across systems by controlling for patient differences, not for simplifying variable selection. Stratification divides populations into subgroups before sampling, which is a different analytical approach entirely. Factor analysis is essential when you're drowning in data and need to identify what really drives your outcomes. 26. A cardiac surgery unit wants to compare its post-operative infection rates to other similar units nationally, but needs to account for the fact that its patients tend to be higher risk with more comorbidities. Which of the following methods should they use to make fair comparisons despite patient differences? A. Factor analysis. B. Stratification. C. Predictive modelling. D. Risk adjustment. Do you know the answer? Correct answer, D. Risk adjustment. Explanation. Option D is correct because risk adjustment uses multivariate regression analysis to statistically level the playing field, essentially asking what would the infection rates look like if both programs had similar patient populations. This enables fair benchmarking and prevents penalising centres that care for sicker patients. Option A is incorrect because factor analysis identifies important variables in datasets, not adjusting for patient complexity and comparisons. Option B is incorrect because stratification divides populations into subgroups before sampling, rather than statistically adjusting outcomes. Option C is incorrect because predictive modelling forecasts future probability outcomes rather than adjusting current comparisons for differences. This question tackles one of the most important concepts in healthcare quality measurement. When a cardiac surgery unit wants to compare their post-operative infection rates to other similar units nationally, but they need to account for the fact that their patients tend to be higher risk with more comorbidities. They must use risk adjustment to make fair comparisons despite patient differences. Here's why this matters. Imagine two cardiac surgery programs, one that serves a predominantly healthy population with few complications, and another that takes the most complex cases with multiple chronic conditions. If you simply compare their raw infection rates, the complex care centre will always look worse, even if they're providing superior care, because their patients are inherently more vulnerable to complications. Risk adjustment uses multivariate regression analysis to statistically level the playing field, essentially asking what would the infection rates look like if both programs had similar patient populations. This enables fair benchmarking and prevents penalising centres that care for sicker patients. Factor analysis identifies important variables in datasets, not adjusting for patient complexity and comparisons. Stratification divides populations into subgroups before sampling rather than statistically adjusting outcomes. Predictive modelling forecasts future probability outcomes rather than adjusting current comparisons for differences. Risk adjustment is fundamental to value-based payment and quality reporting in modern healthcare. 27. A data analyst wants to determine if two hospital departments have significantly different levels of variation in their patient wait times. Which statistical test should they use to compare the spread of their data? A. T-test, B. Z-test, C. F-test, D. ANOVA. Can you guess the answer? Correct answer, C. F-test. Explanation: option C is correct because an F-test is used to compare the variances between two or more groups, making it suitable for determining if the levels of variation in patient wait times are significantly different between the two hospital departments. Option A is incorrect because a t-test is used to compare the means of two groups, not their variances or levels of variation. Option B is incorrect because a z-test is used to compare the means of two groups when the population variances are known, not to compare the variances themselves. Option D is incorrect because ANOVA is used to compare the means of three or more groups, not to compare the variances between groups. Let's dig into understanding statistical tests for comparing variability between groups. When a data analyst wants to determine if two hospital departments have significantly different levels of variation in their patient wait times by comparing the spread of their data, they need an F-test which calculates the ratio of variances to assess equality. Think about what this means. Variance and standard deviation measure how spread out your data is, how much individual wait times differ from the average. An F-test takes the variance from one department and divides it by the variance from the other department to get a ratio. If the variances are equal, this ratio should be close to 1. If one department has much more variable wait times than the other, the ratio will be significantly different from 1, indicating unequal variances. This is important because many other statistical tests assume equal variances, so you often use an F-test first to check this assumption. Tests compare means between groups, asking if average wait times differ, not if the variability differs. Z-tests also compare means for large samples with known variances. ANOVA compares means among three or more groups, again focusing on averages, not variability. The F-test is unique because it specifically examines whether the spread or dispersion of data is similar between groups. 28. A hospital compliance officer needs to access data about Medicare reimbursement rates, hospital quality performance scores, and Medicaid payment policies for strategic planning. Which database should they access? A. CDC, B. NPDB, C. HSCAPS, D. CMS. Do you know the answer? Correct answer, D. CMS. Explanation. Option D is correct because the Centers for Medicare and Medicaid Services provides comprehensive data about Medicare reimbursement rates, hospital quality performance scores, and Medicaid payment policies, essential for strategic planning. Option A is incorrect because the Centers for Disease Control focuses on population health statistics like births, deaths, and disease surveillance, not reimbursement rates or quality scores. Option B is incorrect because the National Practitioner Data Bank maintains individual practitioner information about malpractice and licensure issues, not hospital finances or performance. Option C is incorrect because HCAPS is a patient satisfaction survey tool that measures patient experiences, not a database of financial and quality information. This is about knowing which national database provides specific types of healthcare information. When a hospital compliance officer needs to access comprehensive data about Medicare reimbursement rates, hospital quality performance scores, and Medicaid payment policies for strategic planning, they should access CMS, which stands for Centers for Medicare and Medicaid Services. Think of CMS as the federal agency that not only runs these massive insurance programs, but also collects and publishes extensive data about healthcare costs, quality, and outcomes. CMS maintains detailed information about how much Medicare pays for different services, which hospitals are top performers on quality metrics, and what policies govern Medicaid payments in different states. This data is essential for strategic planning, benchmarking, and understanding the financial landscape of healthcare. CDC, the Centers for Disease Control, focuses on completely different data. Population health statistics like births, deaths, marriages, divorces, and disease surveillance. NPDB, the National Practitioner Data Bank, maintains individual practitioner information about malpractice and licensure issues for credentialing purposes. HCAPS is a patient satisfaction survey tool that measures patient experiences, not a comprehensive database of financial and quality information. Understanding which national database serves which purpose is essential for healthcare leaders who need to make data-driven decisions. 29. A nursing unit manager collects data on patient fall incidents every month for 3 consecutive years to identify trends and patterns. What type of research design are they using? A. Cross-sectional study. B. Case study. C. Meta-analysis. D. Time series analysis. Can you guess the answer? Correct answer, D. Time series analysis. Explanation. Option D is correct because time series analysis involves gathering sequential data at regular predetermined intervals over an extended period to identify trends and patterns, which matches the manager's data collection method. Option A is incorrect because a cross-sectional study captures data at a single point in time, not over a period to identify trends. Option B is incorrect because a case study involves deep investigation of a single unit or situation, not systematic measurements over time. Option C is incorrect because meta-analysis combines results from multiple completed studies, rather than collecting new sequential data. Now let's explore research designs that track patterns over time. When a nursing unit manager collects data on patient fall incidents every month for 3 consecutive years to identify trends and patterns, they're conducting time series analysis, which involves gathering sequential data at regular predetermined intervals for trend identification. Think of time series analysis as creating a detailed timeline that shows how something changes month after month, year after year. The key characteristics are that data points are collected in sequence, at regular intervals, like monthly or quarterly, and over an extended period. This allows you to identify trends like whether falls are increasing or decreasing, spot seasonal patterns like more falls during certain months, and evaluate whether interventions are working by seeing if the trend changes after implementation. Cross-sectional studies are completely different, capturing data at just one specific point in time for a snapshot, not tracking changes. Case studies provide deep investigation of a single unit or situation rather than systematic measurements over time. Meta-analysis systematically combines results from multiple completed studies rather than collecting new sequential data. Time series analysis is particularly valuable in healthcare for monitoring quality indicators, tracking infection rates, and evaluating the sustained impact of improvement initiatives. 30. Which statistical test is most appropriate for a clinical trial measuring blood glucose levels in the same group of patients before and after treatment with a diabetes medication? A. Two-sample t-test. B. Paired t-test. C. Z-test. D. Chi-square test. Do you know the answer? Correct answer, B. Paired t-test. Explanation. Option B is correct because the paired t-test is specifically designed for comparing related observations from the same subjects, such as before and after measurements on the same patients. Option A is incorrect because a two-sample t-test is used for comparing the means of two independent groups, not paired observations. Option C is incorrect because a z-test is appropriate for large samples with known population variances, not for paired data. Option D is incorrect because a chi-square test is used to examine associations between categorical variables, not for comparing numerical measurements like blood glucose levels. This question tests your understanding of when to use paired statistical tests. When a clinical trial comparing two diabetes medications measures blood glucose levels in the same group of patients before and after treatment to assess the medication's effect, they need a paired t-test which is specifically designed for comparing related observations from the same subjects. Think about why this matters. When you measure the same patients at two different time points, the observations are paired or related, not independent. Patient A's before measurement is naturally connected to patient A's after measurement. This pairing reduces variability because you're comparing each patient to themselves rather than comparing different groups of people. The paired t-test accounts for this relationship and is more powerful for detecting real changes than tests designed for independent groups. A two-sample t-test would be wrong because it's designed for comparing two completely independent groups, like comparing one group of patients getting medication A to a different group getting medication B. Z-tests are for large samples with known population variances when comparing means, but they don't account for the paired nature of before and after measurements. Chi-square tests examine associations between categorical variables, completely inappropriate for comparing numerical blood glucose measurements. Understanding when observations are paired versus independent is crucial for choosing the right statistical test. 31. When a population health analyst needs to divide a large community into smaller homogeneous groups based on shared risk factors before conducting sampling for a health needs assessment, they're using what technique? A. Predictive modelling. B. Stratification analysis. C. Risk adjustment. D. Factor analysis. Can you guess the answer? Correct answer. B. Stratification analysis. Explanation. Option B is correct because stratification analysis is the process of dividing a population into homogeneous subgroups based on shared characteristics or risk factors to ensure representation and improve accuracy in sampling. Option A is incorrect because predictive modelling uses algorithms to forecast future outcomes, not to divide populations for sampling. Option C is incorrect because risk adjustment enables fair comparisons by statistically controlling for patient complexity after data is collected, not by dividing populations beforehand. Option D is incorrect because factor analysis identifies important variables in complex datasets, different from creating homogeneous sampling groups for sampling purposes. Let's explore an important analytical technique for improving sampling accuracy. When a population health analyst needs to divide a large community into smaller homogeneous groups based on shared risk factors before conducting sampling for a health needs assessment, they're using stratification analysis, which creates uniform subgroups for more accurate sampling. Think of stratification as organizing people into similar categories before you start your study, kind of like sorting a deck of cards by suit before dealing. The key insight is that populations are often heterogeneous or diverse, and if you just randomly sample everyone together, you might miss important subgroups or get unrepresentative results. By stratifying first, dividing the community into groups like high-risk elderly, medium-risk adults, and low-risk young adults, you ensure that each important subgroup is properly represented in your sample. This improves the accuracy and representativeness of your data collection. Predictive modelling uses algorithms to forecast future outcomes, not to divide populations for sampling. Risk adjustment enables fair comparisons by statistically controlling for patient complexity after data is collected, not by dividing populations beforehand. Factor analysis identifies important variables in complex data sets, different from creating homogeneous sampling groups. Stratification is particularly valuable when studying diverse populations, where different subgroups have very different characteristics or needs. 32. A biostatistician is analysing the relationship between patient age and recovery time after surgery. Both variables can be measured with meaningful numerical differences along a continuous scale. What type of variables are they examining? A. Dichotomous variables. B. Categorical variables. C. Nominal variables. D. Continuous variables. Do you know the answer? Correct answer, D. Continuous variables. Explanation. Option D is correct because continuous variables can take on any value within a range, and the differences between values are meaningful and measurable. Both age and recovery time fit this definition. Option A is incorrect because dichotomous variables have only two possible states, such as yes or no. Option B is incorrect because categorical variables use names or labels as values without numerical meaning, such as types of surgery. Option C is incorrect because nominal variables represent categories or names without any numerical meaning or order. This is about understanding the fundamental characteristics of different variable types. When a biostatistician needs to analyse the relationship between patient age and recovery time after surgery, where both variables can be measured with meaningful numerical differences along a continuous scale, they're examining continuous variables. Think about what makes a variable continuous. It can take on any value within a range, not just specific categories or whole numbers. Age could be measured as 45 years, 45.5 years, or 45.73, 2 years depending on your precision. Recovery time could be 5 days, 5.3 days, or 5.25 days. The values flow continuously along a scale without gaps, and the differences between values are meaningful and measurable. This is fundamentally different from categorical variables, which use names or labels as values without numerical meaning, like types of surgery or insurance categories. Dichotomous variables only have two possible states, like yes or no, alive or dead, which doesn't describe age or recovery time that can have many values. Nominal variables represent categories or names without any numerical meaning or order, completely unlike the measurable age and recovery time in this scenario. Understanding whether variables are continuous, categorical, ordinal, or nominal determines which statistical analyses are appropriate. 33. A medical records department uses a simple database structured as a single table with rows and columns, similar to a basic spreadsheet for tracking patient appointments. What type of database are they using? A. Relational database. B. Multidimensional database. C. Object-oriented database. D. Flat file database. Can you guess the answer? Correct answer, D. Flat file database. Explanation: option D is correct because a flat file database is a simple database model that stores data in a single table, much like a spreadsheet. This is the least complex type of database and is suitable for straightforward data storage and retrieval needs, such as tracking patient appointments. Option A is incorrect because relational databases use multiple tables linked by key fields to establish relationships between different types of data, allowing for more complex queries and reduced data redundancy. Option B is incorrect because multidimensional databases are designed for complex analysis and enable quick processing from multiple perspectives, which is more advanced than a simple single-table structure. Option C is incorrect because object-oriented databases are used to store complex multimedia content, like images and videos, rather than simple rows and columns of text and numbers. Let's understand the simplest type of database structure. When a medical records department uses a simple database structured as a single table with rows and columns, similar to a basic spreadsheet for tracking patient appointments, they're using a flat file database, which describes this straightforward organizational structure with limited functionality. Think of a flat file database as essentially an electronic spreadsheet. Everything is in one table with rows representing individual records, like appointments, and columns representing different pieces of information, like patient name, appointment date, doctor, and reason for visit. The advantage is simplicity. It's easy to understand and doesn't require sophisticated database management skills. However, the limitations are significant. No relationships between different types of data, limited ability to query complex information, and problems with data redundancy, where the same information gets repeated many times. Relational databases are much more sophisticated, using multiple connected tables linked by key fields that can relate patients to appointments to doctors without redundancy. Multidimensional databases enable quick processing from multiple perspectives for complex analysis, far beyond a simple spreadsheet. Object-oriented databases store complex multimedia content, like images and videos, not just simple rows and columns of text and numbers. Flat file databases work fine for very simple applications, but quickly become inadequate as data complexity grows. 34. Which ethical principle in healthcare research prioritizes acting in the best interests of study participants and promoting their overall welfare throughout the research process? A. Autonomy. B. Justice. C. Beneficence. D. Fidelity. Do you know the answer? Correct answer C. Beneficence. Explanation: option C is correct because beneficence is the ethical principle that requires researchers to actively work to promote participant welfare and act in their best interests throughout the entire research process. Option A is incorrect because autonomy focuses on respecting participants' rights to make their own informed decisions about their involvement. Option B is incorrect because justice addresses fairness in how participants are selected and how risks and benefits are distributed across different populations. Option D is incorrect because fidelity concerns a loyalty, truthfulness, and keeping promises to participants. Here's another fundamental ethical principle that guides healthcare research. When a healthcare researcher examining patient outcomes must prioritize acting in the best interests of study participants and promoting their overall welfare throughout the research process, they're upholding the principle of beneficence. Think of beneficence as the ethical commitment to actively do good, and promote well-being, not just avoid harm. It requires researchers to design studies that have potential benefit, to maximize possible benefits while minimizing risks, and to ensure that the research serves the interests of participants and society. This might mean choosing less invasive measurement methods when possible, providing excellent care to all participants regardless of which group they're in, or ensuring that participants have access to successful treatments after the study ends. Autonomy is different, focusing on respecting participants' rights to make their own informed decisions about involvement. Justice addresses fairness in how we select participants and distribute risks and benefits across different populations. Fidelity concerns loyalty, truthfulness, and keeping promises to participants. All these principles work together, but beneficence specifically requires that researchers actively work to promote participant welfare and act in their best interests throughout the entire research process. 35. A quality analyst studying central line infections wants to collect detailed information about a single intensive care unit's practices, protocols, and outcomes through chart reviews and non-participant observation. What type of research is this? A. Case study. B. Longitudinal study. C. Meta-analysis. D. Randomized control trial. Can you guess the answer? Correct answer, A. Case study. Explanation. Option A is correct because a case study involves an in-depth investigation of a single unit to understand practices, protocols, and outcomes using methods like chart reviews and non-participant observation. Option B is incorrect because longitudinal studies gather data over extended time periods from multiple subjects to detect changes and patterns across a population, not an in-depth study of a single unit. Option C is incorrect because meta-analysis systematically combines results from multiple existing studies for greater statistical power, not conducting new in-depth investigation of one unit. Option D is incorrect because randomized control trials involve actively assigning subjects to different interventions and measuring outcomes, which is experimental manipulation rather than observational investigation. Let's explore when to use an in-depth qualitative research approach. When a quality analyst studying central line infections wants to collect detailed information about a single intensive care unit's practices, protocols, and outcomes through chart reviews and non-participant observation, they're conducting a case study which provides this focused, in-depth investigation approach. Think of a case study as putting one particular situation under a microscope to understand every detail of what's happening and why. The researcher doesn't try to manipulate or change anything. They just observe and document thoroughly using methods like reviewing charts, observing procedures, interviewing staff, and analysing protocols. Case studies are perfect when you want to deeply understand the unique characteristics of a specific situation, identify factors that might explain success or failure, or generate hypotheses for future research. Longitudinal studies are different, gathering data over extended time periods from multiple subjects to detect changes and patterns across a population. Meta-analysis systematically combines results from multiple existing studies for greater statistical power, not conducting new in-depth investigation of one unit. Randomized control trials involve actively assigning subjects to different interventions and measuring outcomes, which is experimental manipulation rather than observational investigation. Case studies provide the rich contextual understanding that quantitative methods often miss. 36. A medical researcher is testing a new wound care treatment and must ensure the study design minimizes potential harm to participants, even while pursuing potential benefits. Which ethical principle is the researcher upholding? A. Autonomy. B. Justice. C. Non-maleficence. D. Fidelity. Do you know the answer? Correct answer, C. Non-maleficence. Explanation: option C is correct because non-maleficence establishes the fundamental obligation to avoid causing harm and requires researchers to carefully assess potential risks, design studies to minimize those risks, continuously monitor for adverse events, and stop the study if harm becomes apparent. Option A is incorrect because autonomy is about respecting participants' rights to make independent decisions about involvement, not about the obligation to minimize harm. Option B is incorrect because justice addresses fair selection and equitable distribution of risks and benefits across populations. Option D is incorrect because fidelity involves loyalty, truthfulness, and keeping promises to participants. This tests your understanding of a critical, ethical principle in medical research. When a medical researcher is testing a new wound care treatment and must ensure the study design minimizes potential harm to participants, even while pursuing potential benefits, they're upholding the principle of non-maleficence, which establishes this fundamental obligation to avoid causing harm. Think of non-maleficence as the medical version of the Hippocratic Oath's famous phrase, "First do no harm." This principle requires researchers to carefully assess potential risks, design studies to minimize those risks, continuously monitor for adverse events, and stop the study if harm becomes apparent. It's about being vigilant and protective, ensuring that the pursuit of knowledge doesn't come at the expense of participant safety. While all research involves some level of risk, non-maleficence demands that risks be minimized as much as possible and never exceed potential benefits. Autonomy is about respecting participants' rights to make independent decisions about involvement, not about the obligation to minimize harm. Justice addresses fair selection and equitable distribution of risks and benefits across populations. Fidelity involves loyalty, truthfulness, and keeping promises to participants. Non-maleficence is specifically about that fundamental commitment to avoid causing injury or harm to people who volunteer for research. 37. A hospital administrator wants patient satisfaction survey results that can be compared to national benchmarks and used to calculate performance-based reimbursement. What do they need? A. NPDB, B. CDC, C. Disease registries, D. HCAPS. Can you guess the answer? Correct answer, D. HCAPS. Explanation: option D is correct because HCAPS is specifically designed to measure and compare patient satisfaction across hospitals for quality improvement and payment purposes, and allows hospitals to be benchmarked against each other, with performance affecting Medicare reimbursement. Option A is incorrect because NPDB is the National Practitioner Data Bank for credentialing information about individual providers, not patient satisfaction. Option B is incorrect because the CDC collects population health statistics, like disease surveillance, not patient satisfaction surveys. Option C is incorrect because disease registries track specific conditions for public health reporting, not patient experience. Now we're looking at standardized quality measurement tools in healthcare. When a hospital administrator wants patient satisfaction survey results that can be compared to national benchmarks and used to calculate performance-based reimbursement, they need HCAPS, which stands for Hospital Consumer Assessment of Healthcare Providers and Systems, a standardized survey instrument with 29 questions about hospital stays mandated by CMS. Think of HCAPS as the national gold standard for measuring patient experience. It asks the same questions in the same way at every hospital across the country, which allows fair comparisons. The questions cover communication with nurses and doctors, responsiveness of staff, cleanliness and quietness of the environment, pain management, communication about medications, discharge information, and overall rating. Because it's standardized and required by CMS, hospitals can be benchmarked against each other, and performance affects Medicare reimbursement, creating financial incentives for improving patient experience. NPDB is the National Practitioner Data Bank for credentialing information about individual providers, not patient satisfaction. CDC collects population health statistics like disease surveillance, not patient satisfaction surveys. Disease registries track specific conditions for public health reporting, not a patient experience. HC Apps is specifically designed to measure and compare patient satisfaction across hospitals for quality improvement and payment purposes. 38. A statistical analyst calculated a dataset's range by finding the difference between the maximum and minimum values but needs additional measures to fully describe the data's distribution. Which type of measures are they looking for? A. Measures of central tendency. B. Measures of correlation. C. Measures of spread. D. Measures of significance. Do you know the answer? Correct answer, C. Measures of spread. Explanation. Option C is correct because measures of spread, such as variance and standard deviation, along with the range, describe how data points are scattered or dispersed. They provide insight into the variability within the dataset, complementing the range. Option A is incorrect because measures of central tendency, like the mean, median, and mode, describe the center or typical value of a dataset, not its spread. Option B is incorrect because measures of correlation assess the relationships between two variables, not the dispersion of a single dataset. Option D is incorrect because measures of significance, like p-values, determine if results are statistically meaningful, but do not describe how the data is distributed. This is about understanding how we categorize different types of statistical measures. When a statistical analyst calculated a dataset's range by finding the difference between the maximum and minimum values, but needs additional measures to fully describe the data's distribution, they're looking for measures of spread, which include range along with standard deviation and variance. Think about what measures of spread tell us. They describe how scattered or dispersed the data points are, how much variation exists, whether values cluster tightly around the center or spread out widely. Range is the simplest measure, just the difference between the highest and lowest values. Variance and standard deviation are more sophisticated, measuring the average distance of data points from the mean. These measures are crucial because two datasets can have the same average but very different spreads, and that difference matters. Measures of central tendency are different, including mean, median, and mode, which identify the center or typical value of a dataset rather than describing spread. Measures of correlation assess relationships between two variables, not the dispersion of a single dataset. Measures of significance like p-values determine if results are statistically meaningful, not how data is distributed. Understanding both central tendency and spread gives you a complete picture of your data's distribution. 39. When a clinical researcher analyzes infection data and calculates that 50% of patients fall below a certain infection severity score, what have they identified? A. Mode. B. Range. C. Mean. D. Median. Can you guess the answer? Correct answer, D. Median. Explanation. Option D is correct because the median represents the 50th percentile, meaning 50% of the data falls below it. Option A is incorrect because the mode is the most frequently occurring value, not the value that splits the data in half. Option B is incorrect because the range is the difference between the maximum and minimum values, not a measure of central tendency representing the middle of the data. Option C is incorrect because the mean is the average of all values, which can be influenced by outliers and may not represent the 50th percentile. Let's clarify an important concept about measures of central tendency. When a clinical researcher analyzes infection data and calculates that 50% of patients fall below a certain infection severity score, they've identified the median, which represents this 50th percentile value in the data set. Think about what the median really means. It's the middle value that divides your data set exactly in half, with 50% of observations below it and 50% above it. If you line up all your patients from lowest to highest infection severity, the median is the value right in the middle of that line. The median is particularly useful when you have outliers or skewed data because, unlike the mean, it's not influenced by extreme values. The mean is different. It's the arithmetic average where you add up all values and divide by the count, which can be pulled up or down by extreme values. Mode is the most frequently occurring value, which might not be anywhere near the middle of the distribution. Range measures the spread between maximum and minimum values, not a central value at all. Understanding when to use median versus mean is crucial in healthcare data where we often have skewed distributions and outliers that would distort the mean. 40. A healthcare analytics team needs a database that allows quick processing of massive datasets and enables ad hoc reporting from multiple perspectives or dimensions for strategic decision-making. Which database type is best suited for this? A. Flat file database. B. Transactional database. C. Relational database. D. Multidimensional database. Do you know the answer? Correct answer, D. Multidimensional database. Explanation. Option D is correct because multidimensional databases are designed specifically for rapid processing of large datasets and support ad hoc queries from multiple dimensions, which is crucial for strategic decision-making in healthcare analytics. Option A is incorrect because flat file databases are simple, single table structures that lack the ability to handle complex multidimensional analysis. Option B is incorrect because transactional databases are optimized for real-time operational tasks and lack the analytical processing capabilities required for strategic decision-making. Option C is incorrect because relational databases, while capable of handling multiple tables, do not have the optimization for rapid multidimensional processing needed for healthcare analytics. This question explores specialized database architectures for analytical purposes. When a healthcare analytics team needs a database that allows quick processing of massive datasets and enables ad hoc reporting from multiple perspectives or dimensions for strategic decision-making, they need a multidimensional database, which is specifically optimized for these rapid, multidimensional analytical capabilities. Think of a multidimensional database like a sophisticated data cube, where you can slice and dice information from any angle you want. Want to see patient visits by time of day of week, by diagnosis, by physician, and by payer simultaneously. A multidimensional database can process that complex query quickly. The key features are rapid processing of large volumes of data, ability to view information from multiple dimensions or perspectives at once, and support for ad hoc queries where users can explore data dynamically without predefined reports. Flat file databases are simple single-table structures completely inadequate for multidimensional analysis. Transactional databases handle real-time operational tasks with rollback capability, not complex analytical processing. While relational databases can handle multiple tables well, they lack the specific optimization for rapid multidimensional processing that makes these queries fast and flexible. Multidimensional databases are essential for business intelligence and strategic planning in modern healthcare organizations. 41. A hospital needs to track cancer cases, maintain patient information, and generate public health reports. Which specialized database system is needed? A. Transactional database. B. Data warehouse. C. Object-oriented database. D. Cancer registry. Can you guess the answer? Correct answer, D. Cancer registry. Explanation: option D is correct because cancer registries are specifically designed for tracking cancer cases, patient information, and generating public health reports. Option A is incorrect because transactional databases handle real-time operational tasks, such as processing lab orders. Option B is incorrect because data warehouses store massive amounts of data from multiple organizations for strategic analysis. Option C is incorrect because object-oriented databases are designed for storing multimedia content, like medical images. Alright, let's break down what specialized database systems are designed for specific medical conditions. When a hospital wants to track all cancer cases diagnosed and treated in their facility, maintain comprehensive patient information, and generate required public health reports, they need a cancer registry, which is a specialized database system designed specifically for this disease-specific documentation and reporting. Think of a cancer registry as a dedicated filing system exclusively for cancer patients, where every single case gets its own comprehensive record that follows the patient's journey from initial diagnosis through treatment, outcomes, and long-term follow-up. These registries serve multiple critical purposes. They enable hospitals to track their cancer care quality, they provide data for research into cancer patterns and treatment effectiveness, and they fulfill mandatory public health reporting requirements that help identify cancer trends in communities. This is completely different from transactional databases, which handle real-time operational tasks like processing lab orders with rollback capability, not long-term disease tracking. Data warehouses store massive amounts of data from multiple organizations for strategic analysis and mining, but they're not focused on the detailed case-by-case tracking that registries provide. Object-oriented databases are designed for storing multimedia content, like medical images, audio recordings, and videos, not for the structured disease-specific case tracking and reporting that cancer registries do. Cancer registries are essential public health tools that help us understand cancer patterns and improve treatment outcomes. 42. Which ethical principle is upheld when a clinical researcher demonstrates loyalty to study participants, maintains truthfulness in all communications, and serves as an advocate for patient interest throughout the research? A. Autonomy. B. Beneficence. C. Fidelity. D. Justice. Do you know the answer? Correct answer, C. Fidelity. Explanation: option C is correct because fidelity in research ethics involves faithfulness, loyalty and promise-keeping, including maintaining truthfulness and advocating for participants' interests. Option A is incorrect because autonomy focuses on the participants' right to make informed decisions about their involvement in the study. Option B is incorrect because beneficence is about actively promoting the welfare and best interests of the participants, but does not specifically emphasize truthfulness and promise-keeping. Option D is incorrect because justice relates to the fair selection of participants and equitable distribution of research benefits and risks across different groups. Now we're exploring another fundamental ethical principle that governs researcher-participant relationships. When a clinical researcher must demonstrate loyalty to study participants, maintain complete truthfulness in all communications, and serve as an advocate for patient interests throughout the research, they're upholding the principle of fidelity, which encompasses these obligations of faithfulness and promise-keeping. Think of fidelity as the ethical foundation of trust in the researcher-participant relationship. It's about being worthy of the trust that participants place in you when they agree to be in your study. Fidelity means if you promise participants that their data will be confidential, you keep that promise. If you tell them the study will last 6 months, you don't extend it to 12 without their consent. It means advocating for their interests when conflicts arise, being honest about risks and benefits, even when it might hurt recruitment, and maintaining loyalty to participants rather than letting other pressures like funding or publication push you to compromise their welfare. Autonomy is different, focusing on participants' rights to make their own informed decisions about involvement, not the researcher's obligations of loyalty. Beneficence concerns actively promoting participant welfare and acting in their best interests, which overlaps with fidelity but doesn't specifically address truthfulness and promise-keeping. Justice addresses fair selection and equitable distribution of risks and benefits across different groups. Fidelity is what makes participants willing to trust researchers with their health information and participation, because they know the researcher will be loyal, truthful, and keep their promises. 43. What type of database architecture connects multiple tables using key fields to link related information across departments while maintaining data integrity, commonly used in large hospital systems? A. Flat file database. B. Multidimensional database. C. Object-oriented database. D. Relational database. Can you guess the answer? Correct answer, D. Relational database. Explanation. Option D is correct because relational databases are designed to connect multiple tables through key fields, ensuring data integrity and reducing redundancy, making them suitable for large hospital systems needing to link information across departments. Option A is incorrect because flat file databases store data in a single table, lacking the relationships and data integrity features needed for complex systems. Option B is incorrect because multidimensional databases are optimized for analytical reporting and quick processing from multiple perspectives, not for managing transactional data with integrity constraints. Option C is incorrect because object-oriented databases are designed to store multimedia content and complex data structures, rather than focusing on relational integrity and efficient querying of structured data. Let's dive into understanding the most common type of database architecture in healthcare. When a large hospital system needs a database architecture that connects multiple tables using key fields to link related information across departments while maintaining data integrity, they need a relational database, which uses this interconnected table structure with linking fields. Think of a relational database like a well-organized city where different neighborhoods are connected by roads. Each table is like a neighborhood containing related information, and key fields are like the roads that connect them together. For example, you might have a patient table with patient ID, name and contact information, an appointment table with appointment ID, patient ID, date and doctor ID, and a doctor table with doctor ID, name and specialty. The patient ID and doctor ID are key fields that link these tables together, allowing you to ask complex questions, like which patients have appointments with cardiologists next week. This maintains data integrity because each piece of information is stored in only one place. If a patient's address changes, you update it once in the patient table, and all related records automatically reference the updated information. Flat file databases are just single tables like spreadsheets without these connections. Multidimensional databases focus on quick processing from multiple perspectives for analytical reporting, using a different structure. Object-oriented databases store multimedia content rather than using linked tables with key fields. Relational databases are the backbone of most healthcare information systems. 44. The value appearing most frequently among all patient wait times is identified as 15 minutes. Which measure of central tendency does this represent? A. Mean. B. Median. C. Mode. D. Variance. Do you know the answer? Correct answer, C. Mode. Explanation. Option C is correct because the mode identifies the value that appears most frequently in a dataset. In this case, a wait time of 15 minutes is the most frequent, which defines the mode. Option A is incorrect because the mean is the arithmetic average of all values and is calculated by summing all values and dividing by the count, which is not represented in this scenario. Option B is incorrect because the median represents the middle value that divides the dataset in half, with 50% above and 50% below, which is not related to the most frequent value. Option D is incorrect because variance is a measure of spread that describes how far values deviate from the mean, rather than a measure of central tendency. This is about identifying which measure of central tendency to use in different situations. When a dataset shows that the value appearing most frequently among all patient wait times is 15 minutes, we're looking at the mode, which identifies this most commonly occurring value in the distribution. Think about what the mode tells us that other measures don't. It's the value you'd encounter most often if you randomly picked observations from your dataset. In a hospital emergency department, knowing that the mode wait time is 15 minutes tells administrators that 15 minutes is the most common patient experience, even if the mean might be higher due to some very long waits. The mode is particularly useful for understanding typical experiences and is the only measure of central tendency that makes sense for nominal or categorical data. The mean is different, calculated by adding all values and dividing by the count, so it gives you the arithmetic average, which can be skewed by extreme values. The median is the middle value that divides the dataset in half, with 50% above and 50% below. Variance isn't even a measure of central tendency at all. It's a measure of spread that describes how far values deviate from the mean. Understanding when to use mode versus mean versus median depends on your data distribution and what question you're trying to answer about typical or central values. 45. When a researcher comparing emergency department wait times between two independent hospitals with small sample sizes of 20 patients, each needs to determine if there is a significant difference in average wait times, they should use A, paired t-test, B, two-sample t-test, C, ANOVA, D, chi-square test. Can you guess the answer? Correct answer, B, two-sample t-test. Explanation: option B is correct because a two-sample t-test is appropriate for comparing the means of two independent groups with small sample sizes, as in this scenario comparing wait times from two different hospitals. Option A is incorrect because a paired t-test is used for related observations, such as measuring the same patients before and after an intervention, not two different groups of patients. Option C is incorrect because ANOVA is designed for comparing the means of three or more groups simultaneously, while this scenario involves only two hospitals. Option D is incorrect because a chi-square test is used for examining associations between categorical variables, not for comparing means of numerical continuous data like wait times. Let's clarify when to use different types of t-tests based on study design. When a researcher comparing emergency department wait times between two independent hospitals with small sample sizes of 20 patients, each needs to determine if there is a significant difference in average wait times, they should use a two-sample t-test, which is appropriate for this scenario. Think about what makes this a two-sample t-test situation. You have two completely separate independent groups of patients from two different hospitals. The patients in Hospital A have no relationship to the patients in Hospital B. They're independent samples. You're comparing the mean wait time from one hospital to the mean wait time from the other hospital, and your sample sizes are small, 20 patients each, which is less than 30. The two-sample t-test, sometimes called an independent samples t-test, is specifically designed for exactly this situation. A paired t-test would be wrong because that's for related observations, like measuring the same patients before and after an intervention, not two different groups of patients. ANOVA would be overkill because it's designed for comparing three or more groups simultaneously, and we only have two hospitals here. Chi-square tests are completely inappropriate because they're for examining associations between categorical variables, and wait times are numerical continuous data, not categories. The key decision point is recognizing that these are two independent groups with small sample sizes comparing means, which screams two-sample t-test. 46. When a healthcare quality director calculates that the average patient satisfaction score is 8.5 on a 10-point scale, by adding all scores and dividing by the total number of patients, they've calculated the what? A. Mode, B. Median, C. Range, D. Mean. Do you know the answer? Correct answer, D. Mean. Explanation: option D is correct because the mean is calculated by summing all values and dividing by the number of values, which is exactly what the director did. Option A is incorrect because the mode is the most frequently occurring value in a data set, not calculated by summing and dividing. Option B is incorrect because the median is the middle value when data is ordered, not the result of an arithmetic average. Option C is incorrect because the range is the difference between the highest and lowest values, not a measure of central tendency found by summing and dividing. This question tests whether you understand how different measures of central tendency are calculated. When a healthcare quality director calculates that the average patient satisfaction score is 8.5 on a 10-point scale by adding all scores and dividing by the total number of patients, they've calculated the mean using this arithmetic method. Think about what the calculation process tells us. The mean is literally the arithmetic average. You sum up every single value in your dataset and then divide by how many values you have. If you surveyed 100 patients and their satisfaction scores added up to 850, you divide 850 by 100 to get 8.5. The mean is the most commonly used measure of central tendency because it uses all the data points and has nice mathematical properties that make it useful for further statistical analysis. However, the mean has a weakness. It's sensitive to extreme values or outliers. A few very low or very high scores can pull the mean up or down. The median's different. It's the middle value when you arrange all scores in order, not calculated by summing and dividing. The mode is the most frequently occurring value, which might not even be close to the arithmetic average. Range isn't a measure of central tendency at all. It measures spread by finding the difference between the highest and lowest values. When someone describes calculating an average by adding and dividing, they're always talking about the mean. 47. Which statistical method measures relationships between variables? A. F-test, B. Mann-Whitney, C. Chi-square, D. Pearson's correlation. Can you guess the answer? Correct answer, D. Pearson's correlation. Explanation: option D is correct because Pearson's correlation is used to measure the strength and direction of a linear relationship between two variables. It's suitable for ordinal data, like pain level ratings, when the ordinality is strong, and gives a value between -1 and +1, indicating the correlation strength. Option A is incorrect because an F-test is used to determine if two population variances are equal, not to measure relationships between variables. Option B is incorrect because the Mann-Whitney U-test compares the means of two groups and does not measure correlation or relationship strength between variables. Option C is incorrect because the chi-square test is used to assess the association between categorical variables, such as insurance type and readmission status, not the relationship between ranked or numerical scales. Now we're looking at which statistical method measures relationships between variables. When a clinical trial researcher needs to analyse whether there is a correlation between two variables measured on ordinal scales, such as pain level ratings and activity limitation scores, they should use Pearson's correlation, which is appropriate for measuring this relationship between ranked variables. Think about what correlation means. It measures how two variables move together. When one goes up, does the other tend to go up too, which would be positive correlation, or does the other go down, which would be negative correlation, or do they seem unrelated with no pattern? Pearson's correlation gives you a number between -1 and +1 that quantifies this relationship. -1 means perfect negative correlation, 0 means no linear relationship, and +1 means perfect positive correlation. While Pearson's is technically designed for interval or ratio data, It's commonly used with ordinal data like rating scales when the ordinality is relatively strong. Choose square is completely wrong because it tests associations between categorical variables like insurance type and readmission status, not the strength of relationship between numerical or ranked scales. Mann-Whitney U compares means between two groups. It doesn't measure correlation or relationship strength. F-tests determine if two population variances are equal. Again, not about measuring relationships between variables. When you need to quantify how strongly two variables are related, correlation analysis is the tool, and Pearson's is the most common method. 48. A hospital epidemiologist collects data from the same group of healthcare workers over an entire year to understand how a disease outbreak has progressed. What type of study is this? A. Cross-sectional study. B. Case study. C. Longitudinal study. D. Meta-analysis. Do you know the answer? Correct answer, C. Longitudinal study. Explanation option C is correct because a longitudinal study involves repeated observations of the same variables over long periods of time, often many years, to detect changes and trends. Option A is incorrect because a cross-sectional study captures data at a single point in time, offering a snapshot rather than tracking changes over time. Option B is incorrect because a case study is an in-depth analysis of a single individual, group, or event, not a study, tracking changes in a group over time. Option D is incorrect because a meta-analysis combines the results of multiple scientific studies to develop a single conclusion, not tracking the same subjects over time. This is about understanding research designs that follow subjects over time to detect changes. When a hospital epidemiologist wants to understand how a disease outbreak has progressed by collecting data from the same group of healthcare workers over an entire year to observe changes, they're conducting a longitudinal study, which gathers data over extended time to detect these changes and potential cause-effect relationships. Think of longitudinal studies as following the same group on a journey over time, watching how things evolve and change. The key characteristic is that you're measuring the same subjects repeatedly at multiple time points, allowing you to see individual trajectories of change and identify patterns that emerge over time. This design's powerful for understanding cause and effect because temporal ordering is clear. If exposure happens before outcome, that supports a causal relationship. Longitudinal studies can be cohort studies where you follow a group forward in time, or panel studies where you collect data at regular intervals. Cross-sectional studies are the opposite, capturing data at just one point in time like a snapshot, which can't show how things change. Case studies provide deep investigation of either a single subject or unit, not tracking the same group over extended periods. Meta-analysis combines results from multiple existing completed studies rather than collecting new data from subjects over time. Longitudinal designs are essential when you need to understand change, development, and temporal relationships. 49. A statistical researcher testing a hypothesis with a very large sample of 500 patients and known population variance wants to determine if there is a significant difference from expected values. Which test should they use? A. T-test. B. Z-test. C. F-test. D. Chi-square test. Can you guess the answer? Correct answer, B. Z-test. Explanation: option B is correct because a Z-test is appropriate when dealing with a large sample size, typically greater than 30, and when the population variance is known. These conditions allow for the use of the standard normal distribution, making the Z-test more powerful in this scenario. Option A is incorrect because a t-test is used when the sample size is small, typically less than 30, and the population variance is unknown. Option C is incorrect because an F-test is used to compare the variances of two or more populations, not to test for a significant difference from expected values. Option D is incorrect because a chi-square test is used to examine associations between categorical variables, not for numerical data or testing hypotheses about means. This question is about choosing the right statistical test based on sample size and variance knowledge. When a statistical researcher testing a hypothesis with a very large sample of 500 patients and known population variance wants to determine if there is a significant difference from expected values, they should use a z-test, which is most appropriate for this large sample scenario. Think about what distinguishes a z-test from other tests. It's specifically designed for situations where you have a large sample size, typically defined as greater than 30, and you know the population variance or standard deviation. With 500 patients, we're well above that 30 threshold. The z-test is based on the standard normal distribution, that classic bell curve, and it's more powerful than t-tests when these conditions are met, because it makes fewer assumptions and uses the known population parameters. The mathematical difference is that t-tests use the t-distribution, which has fatter tails to account for uncertainty from smaller samples, while z-tests use the standard normal distribution, because large samples give us more confidence. T-tests would be used for smaller samples, typically less than 30, where we have more uncertainty. F-tests compare variances between populations, asking if they're equal, not testing for significant differences from expected values. Chi-square tests examine associations between categorical variables, completely inappropriate for numerical data, and hypothesis testing about means. The key decision factors are large sample size and known variance, both pointing clearly to the z-test. 50. A researcher wants to compare the mean satisfaction scores from survey data collected from multiple hospitals. There are 3 or more groups of hospitals, and the researcher assumes a normal distribution and similar variance. Which statistical test should the researcher use to compare the mean satisfaction scores simultaneously across all locations? A. T-test, B. Chi-square test, C. ANOVA, D. Mann-Whitney U-test. Do you know the answer? Correct answer, C. ANOVA. Explanation: option C is correct because ANOVA is designed for comparing means across 3 or more groups simultaneously when the data is normally distributed and the variances are similar. It determines if there are statistically significant differences between the means of these groups. Option A is incorrect because a t-test is used to compare the means of only 2 groups, not 3 or more. Option B is incorrect because a chi-square test is used to analyse categorical data, not to compare means of numerical data. Option D is incorrect because the Mann-Whitney U-test is a non-parametric test used to compare 2 groups when the assumption of normality is not met. In this scenario, normality is assumed, and there are more than 2 groups. Let's conclude with understanding when to use ANOVA for comparing multiple groups. When a researcher analysing survey data from multiple hospitals with 3 or more groups needs to compare mean satisfaction scores simultaneously across all locations while assuming normal distribution and similar variance, they should use ANOVA, which is designed for this multi-group comparison scenario. Think about why ANOVA, which stands for analysis of variance, is needed here. You have 3 or more hospitals, and you want to know if the satisfaction scores differ significantly across them. You could theoretically run multiple t-tests, comparing hospital A to B, then A to C, then B to C, but this creates statistical problems because each test increases your chance of false positives. ANOVA solves this by testing all groups simultaneously in one analysis. It works by comparing the variation between group means to the variation within groups. If the between-group variation is much larger than the within-group variation, that suggests real differences exist. ANOVA requires certain assumptions: normal distribution of data, similar variances across groups, and independent observations. TT tests can only compare 2 groups at a time, so they're inadequate when you have 3 or more hospitals. Chi-square tests are for categorical variables not for comparing numerical mean scores. Mann-Whitney U is a non-parametric test for two groups when normality assumptions aren't met. But we have three or more groups here, and we're told to assume normal distribution. When you see three or more groups and you need to compare means, ANOVA is almost always the answer. You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.